Good morning. Can everybody hear me okay? Perfect. So I'm usually a pacer, so I'm going to try to do my best to stay on this podium so that everybody can hear me. Thank you for that kind introduction. So again, my name is Alejandro. I'm a pediatric gastroenterologist here at CS Mott, which is 5 minutes away. So I hope you're having a great time at Ann Arbor, or have had a great time in Ann Arbor this weekend. It's a wonderful place to be. So thank you for coming. This lecture, if you will, or this presentation is a mix of different concerns, disease states, um, syndromes that have been associated with patients with ASXL related disorders. And it's a lot of different topics. And so I'm going to move through it fairly quickly, but I wanted to both use this as a place for you to um, understand and learn a little bit more about these conditions, but also maybe it might spark something in you and something that you can follow up with your primary doctor or your primary GI doc back home. Um, as the name of the game has always been to make sure that our children are their quality of life is improved, and anything that we can do to make that better, I think will go a long way for everybody involved. So let's get through this. It's a lot of things. We'll leave the questions until after so that I can kind of get through everything. But the first thing that I wanted to essentially go through is what are we going to talk about today, right? So first, I'm going to introduce what you all have identified as being the most common GI disorders in your own loved ones. Then we're quickly going to go a little bit over growth. We're going to spend a long time in feeding intolerance and the vomiting realms, and that seems to be a very common disorder. And then we're going to spend some time, and probably my favorite topic as a pediatric GI, which is defecation concerns. I know it's a weird thing to say out loud, but I promise um, it's something. And then at the end we'll have a chance to I'll have a chance to answer some of your questions. And ideally we would keep these on the generalized side so that everybody can kind of relate. But certainly I look forward to your questions as well. So through both the natural history studies and also through you all answering surveys, we have a pretty good idea as to what are the most common GI disorders in your kids, in your family members, in your loved ones. And across the board, across the three independent disorders, we have noted that feeding issues, growth issues, vomiting, reflux, and constipation seem to be the things that are giving you a hard time and that are leading to a poor quality of life for your children. And so that's what I'm going to spend most of my time on today. Starting with feeding concerns, I was reading through this paper that shows the growth curves for ASXL3 children, and this is something really unique. This is not something that we have for a lot of rare disorders, so this is wonderful to have. But some of the things that we noted, or that the study researchers noted, was that these babies are born the same weight, size as children without ASXL, which I think is very interesting. But very quickly, um, it becomes quite clear that they're smaller than their peers. And there's a lot of reasons for that, and we'll go into some of those. But certainly, there is early on, typically within the first 5 years of life, of this concept known as growth faltering. You might hear it as being called failure to thrive. That term is old and no longer in use. The new term is growth faltering, and really that's the term that we should be using because nobody is failing. Um, and depending on the disorder, they might also have smaller heads as well. About 30% of these children come with a diagnosis. Again, I use the older term here because you're probably most familiar with it, of growth faltering. And around the age of 6, 7, the pattern flips. Um, Thank you for that. Yes, thank you. Regardless of what age they are, however, we have noticed that children are either 1 to 1.2 standard deviations above or below what the comparison peers would be. So there's certainly differences in growth and size and weight. And early on, it's really weight faltering, and then later on in life, it's the opposite. And and these children seem to develop obesity or much higher BMIs. Um, these were also interesting facts that I found as I was reading through the literature that's available. We'll talk about a lot of these things through our talk today, but feeding difficulties are really, really common. And is this the reason why the early on children ASXL related disordered children are not growing well? It's possible. There's certainly more to it, I'm sure, but it's a very, very common concern. About a quarter of ASXL3 children require some sort of feeding support early in life, whether that is in the way of a nasogastric tube or a G tube. This seems to be a very common concern. It is also notable to say that these feeding difficulties either change or seem to improve as the children grow, and in fact may actually lead to later on the opposite occurring, where children become overweight. And we think that this may be due to, as I'll allude to it later, dysregulated eating patterns as well. So, I'm sure the parents with babies with ASXL related disorders might be wondering, why is my baby not growing? And again, we don't fully know quite yet. There's not one thing that we can point towards, but it's very possible that in similar like in similar genetic conditions, that perhaps the baby is just meant to be small from the get-go. We know that this is common in other genetic disorders, short stature, low weight, especially early on. However, there's clearly more to this than just that, right? Feeding difficulty is very common, and it could be due to mouth or facial deformities, to oral motor impairments, such as the discoordination between the mouth, the tongue, and the throat, and then potentially even low appetite or disinterest in feeding how we would expect a baby to feed. Other conditions, systemic conditions, especially those involving the heart and the lungs, those are very caloric intensive conditions. And so it's possible that because of these conditions, they just require much higher amount of calories per day. Reflux, which we'll get a chance to talk about today, and colic, which we will not talk about today because that is a whole topic in and of itself, can also lead to sort of chronic vomiting, chronic intolerance of feeds. And then a lot of the medications that your loved ones are on can act to both decrease the appetite, but also slow down the gut to the point where they could become intolerant to not just their feeds, but even their own secretions. On the flip side, why is my older child, teenager, becoming obese? Again, it's possible that because of this being neurodevelopmental and growth disorder, that perhaps they were meant to be shorter than expected. And unfortunately, in the earlier half of their life, we were so concerned about feeding that it's possible that they may have developed some maladaptive feeding behaviors, such as binging, oral fixations, or hyperphagia, which is just eating a lot or wanting to eat a lot. It is very common for them to have also restrictive diets, and typically to want things that are high in carbs, high in fat, high in calories in general. And then texture and taste hypersensitivities, I'm sure, also play a role in this. Hypotonia or low muscle tone can also play a role in this, which kind of feeds into the other things such as poor locomotion or living a fairly sedentary lifestyle. Can again lead to less energy expenditure and increased risk for becoming obese. Thyroid disorders such as hypothyroidism or low thyroid can put you at risk for also being overweight. And then once more, the medication effects coming around, right? Some of these medications can also impact or can make you more hungry than usual, or want to gravitate towards different types of food, and can slow down your gut as well, as I mentioned before. Finally, where we will be spending the bulk of our talk today is why is my child vomiting? And this is just a brief list of kind of the rare and common reasons why your child might have a chronic vomiting disorder. Um, but what I really sort of keep hearing is that it might be a combination of multiple things, as again, as it often is. Um, I will go through some of these in more detail, and so you'll see these again. I wanted to just put just a quick plug about feeding tubes in general. And, they are they can be life-changing for some families, for some patients. Um, it shouldn't be necessarily our goal. We really should try to do always what we can via the mouth, but that's not always possible. Um, these are for the most part, simple surgeries, and they can make a huge difference in the quality of life of you as a caregiver, but also of your children. Um, there are different types of tubes, nasogastric being going through the nose and into the stomach, gastrostomy tubes that go directly from the skin to the stomach, nasojejunal tubes, again, nose to jejunum, which is the second part of the small intestine, and then gastrojejunal, stomach to small intestine. And I use these quite a lot, not just for feeds, but also sometimes for hydration and the administration of medications, especially in children who have flares of vomiting where you cannot get anything in them by mouth sometimes, and this can be helpful in similar scenarios. So, as I promised, we'll go through a few of these disorders fairly quickly. But again, you'll get a chance to ask some questions if you have more concerns or if you want to know a little bit more about each of these disorders. Before I jump into that, though, it's really important that to recognize that a lot of these issues are diagnosed clinically. I wish that I had blood tests for the majority of these. I don't. I wish that I had imaging studies for these. Some of them I do, some of them I don't, right? It really comes down to what I see clinically, what you tell me, what you tell your doctors, and being as specific and as descriptive as you can be, because that can really make a difference. And these are just some of the examples of how that can be the case, right? So food allergy, food insensitivity, for the most part, these typically should not come on unless the food that they're insensitive to is being exposed or they're being exposed to that food. Now, becomes tricky because some of them are immediate reactions. Some of them can take days and weeks to really see the effect. So that can be really tricky. But certainly, if you feel like there is a dietary trigger, bring it up. Let us know about that. Gastroparesis, this is usually fairly stereotypical, but anytime that you challenge the stomach, may be by giving them liquids, feeds, or medications, you'll see symptoms. Cyclic vomiting syndrome, again, very stereotypic pattern. Episodes of no vomiting, followed by episodes of scary amounts of vomiting to the point where you have to take them to the ER. And then reflux, I think we're all pretty familiar with what reflux looks like, but typically symptoms right after eating or when spending lots of time laying flat. A few words about food intolerance versus food allergy. So in general, a food intolerance doesn't typically involve the immune system. It's usually a lack or a reduced activity in the enzymes that usually break down this food in your stomach or in your small intestine. Common examples: lactose intolerance, fructose intolerance. Less common examples, something like galactosemia. Typical symptoms, which you'll see are pretty much similar amongst each other, are diarrhea, vomiting, bloating, a rash, and sometimes abdominal pain. How do you treat it? You avoid the food, and in some situations, we do have replacement enzymes that can help. That is in contrast to a food allergy, which does involve the immune system. Now, there is not just one thing that it can involve. There are such things as IgE versus non-IgE mediated allergies, and that just means that it's involving a very specific antibody. And typically, how you can tell the difference is that those that are IgE are kind of your stereotypical anaphylactic reactions or skin rashes that you see, versus those that are non-IgE mediated can be very delayed by hours, days, and sometimes weeks. Common examples are food protein-induced enterocolitis, or FPIES is another one that is very uncommon, but certainly tends to make the news quite a bit. And I'll tell you about those a little bit as well. Again, I already brought up this point, but this is the difference between IgE-mediated and non-IgE-mediated allergies. IgE-mediated ones are immediate, usually fairly scary and sometimes life-threatening. And this is where our skin prick tests with your allergist are really helpful. In non-IgE-mediated allergies, the effect is the symptoms are delayed, and unfortunately, and thankfully, I don't have an allergist on the audience. Typically, skin pricks are not very helpful. Neither is blood testing, though that seems to be changing. So hopefully, pretty soon we'll have better skin prick tests for this specific type of condition. Just a quick something that you can kind of come back to later, and if you want to. But what are the difference between the three different types of non-IgE mediated food allergies? Well, typically, FPE, for example, your symptoms are going to be vomiting, weight faltering, abdominal distension, and diarrhea. This is what most people tend to talk about when most people think about when they're thinking about cow milk protein allergy, for example. The diagnosis is 99% of the time clinical, but if they happen to do an upper endoscopy during those times and they take biopsies, you might see some findings on there that are pretty classic for this condition. The middle one, FPIEP, is specifically really only has one good symptom, which is rectal bleeding, which is scary enough that we hear about this quite a bit from parents. So it's easy to identify most of the time. But really, otherwise, the children are doing well. They're tolerating their feeds. Really, the only finding is that bloody poop. Sometimes it can be pretty subtle. Sometimes it can be pretty dramatic. Again, diagnosis is typically clinical and is a diagnosis of exclusion, making sure that nothing else might be leading to the rectal bleeding. In contrast to the other two, FPIES is quite scary. These children show up to our ERs hypotonic. They come to our ERs lethargic, looking like they're in septic shock, and then we recover them, and then this happens again later on, and then the second and the third time, and then we realize this is not sepsis. They are not bacteremic. In fact, their body is just having a very strong reaction to a food or some sort of other allergen. This one, again, clinical diagnosis is kind of that stereotypical reaction. And for this one specifically, to really nail the diagnosis, you need to expose the child to the food and kind of link the reaction to the food. So it can be very anxiety producing for sure. The treatment, you identify the trigger and you avoid it. There's really, unfortunately, not much else we can do. Most of the time, that is a fairly easy to eliminate food trigger, but not always. And then the nice thing, though, is that this can be and is often outgrown. The first two are usually outgrown by the age of 1 or 2, while FPIES can take a little bit longer to outgrow. And then eventually you are able to reintroduce the food, by the way, most of the time, not always. Let's change gears a little bit. Let's talk a little bit about reflux. I'm sure you're all aware what reflux is kind of in a broader sense, but reflux is a normal physiologic process. Most of us are doing it up to 70 times in a 24-hour period. And why does that occur? Well, the LES, or the lower esophageal sphincter, which is that sphincter at the bottom of your esophagus right before you get into the stomach, it relaxes every time that you swallow. Every time they swallow your spit, every time they swallow something to drink, something to eat, it has to let it into the stomach, so it has to open up. In that 2 to 2 second time frame, you can have some refluxate, so some of the stomach contents going up into the esophagus, and that is considered GER, or gastroesophageal reflux, and it becomes GERD, the disease, when it is occurring too frequently, it is occurring at inappropriate times, and it's causing damage to the lower part of the esophagus. So that's the distinction between GER and GERD. This is why, our sometimes when our babies are refluxing a ton, we call them happy spitters because we expect this to be normal for the most part for most of those babies. And then just a quick plug for reflux hypersensitivity. If your child happens to have a visceral hypersensitivity or just an extra sensitive gut and brain, you can sometimes have a child who is who has a lot of symptoms, even though they might have normal amounts or normal patterns of reflux on studies. Um, common causes of GERD in pediatrics that also I think translate well to the ASXL community are hypotonia, right? So any time of lower muscle bulk, whether that is, and this is typically more in the diaphragm, the breathing muscle, which supports the lower esophageal sphincter, but you can actually see it in the lower esophageal sphincter as well. A lot of these medications inappropriately relax that lower esophageal sphincter, so again, put you at higher risk for developing GERD. Abnormal gut motility, this is fairly rare, but it can be a cause of it. There's this term called TLESR, say that 10 times fast, which is this, the LES is just kind of really, really slow to close. There is also conditions of the esophagus where the esophagus doesn't fully clear. So even though we are refluxing 70 times in 24 hours, our esophaguses are clearing that back down, and that allows that prevents the damage to the esophagus. The light gastric emptying, if you hold on to too much stuff in your stomach, you're more likely to reflux that stuff. Skeletal dysplasia, the typical dynamics of the body. Any disruption to that can sometimes put strain on certain parts of the diaphragm or kink the diaphragm in a certain way that you lose its protective compression of the lower esophageal sphincter, so that can cause scoliosis. And then hiatal hernia, which is where the stomach slides a little bit into the chest cavity, can also put you at risk for gastric reflux disease. How do we treat it? It really depends, right? So we tried our best to introduce lifestyle changes and precautions to prevent and minimize the amount of reflux that is occurring. I'm sure you've all heard about this at one point or another. Pace feeding, increasing the upright time, using hydrolyzed formulas or formula thickening. When those don't work, which unfortunately is common, medications are then deployed. Histamine 2 receptor blockers, those are your medications that will end in tidine. I think of those as kind of the milder to moderate acting medications, and usually are first line, and then proton pump inhibitors, which end with prazoles, and those are more of the intense medications that we deploy in this scenario. In very rare situations, we might need to go to surgery for this, though I will tell you that I am not a big fan of fundos. I think that we definitely overcorrected 10, 15 years ago, and we're kind of seeing the unfortunate results of that. So this really should be a last resort type of situation. If your child is having a lot of aspiration pneumonia, it's already seen that the lungs are taking a hit from the amount of reflux that is occurring, this can be considered, but it really should be something that we should do with caution. Gastroparesis, the whole concept is the stomach is not emptying at the appropriate rate, right? Slow stomach emptying. Now, this can be part of the child's kind of genetic destiny, if you will, but it can also be acquired. I see this a lot in patients that have really severe viral infections that might develop what we call a post-infectious gastroparesis that can last anywhere from 1 week to up to a year. So it can be something that can be temporary. What causes it? We're not sure, but there's a lot of different things that can go wrong in the stomach that might lead to it not emptying as quickly. So poor stomach accommodation or not being able to hold on to as much as it should. Sphincter disorders or sort of dysfunction of that pylorus right at the bottom of the stomach. Poor stomach contractility, stomach not being able to squeeze as strongly or as long as it normally is able to. And then neuropathic disorders. The stomach, much like the rest of the gut, is an electrical organ. And so you can have poor electrical conductivity to those areas that can cause slow stomach emptying. Thankfully, we have a lot of different ways that we can treat these. This is one of my favorite disorders to treat because we have so many options. Your first line is most likely going to be what we like to call vitamin P in pediatric GI, which is periactin. Not because it's necessarily treating the motility of the stomach or allowing it to empty better, but because it treats a lot of the side effects or a lot of the symptoms of gastroparesis itself. It's a great medication for nausea. It's a great medication for abdominal pain. It has a side effect that increases appetite, so it's really nice in that way. And so we usually start with this because it's well tolerated and and it works well. If that doesn't work, then we have about 3 to 4 options, depending on who you talk to, with erythromycin, metoclopramide, known as Reglan, and prucalopride, known as Motegrity. And these are true prokinetics in the sense that they actually get the stomach moving forward and emptying better. If either this is becoming too much, the patient is not growing well, then sometimes we may just say, you know what, we get it, you have gastroparesis, we're just going to skip the stomach altogether, feed you into the small intestine, allow you to grow a little bit, buy you some time, and sometimes that can become permanent, but certainly one of the ways that we can treat this is just essentially skipping the stomach altogether. For the really severe gastroparetics, venting of the stomach is sometimes a crucial part of their management. And so whether that is done via a Farrow bag or a chimney syringe or into a diaper depends on the severity of the patient's condition. And then kind of more rare ways to treat this is, especially if the concern is the pylorus, we can actually inject the pylorus with Botox endoscopically. It's something that I like to do because it's temporary and fairly safe to do and can help a lot, especially if the issue is right at the sphincter. And then gastric pacing, if it's an electrical problem, a few centers around the country do have great gastric pacing centers where we literally put a pacer in the stomach that allows to normalize that electrical activity a little bit more. But again, that's pretty out there. It's pretty rare to need that, but it is an option. Cyclic vomiting syndrome. This is a fairly uncommon condition. And stereotypically, at least in the general population, this shows up as episodes of severe vomiting to the point where the patient may become highly dehydrated and require a prolonged gut rest and sometimes even sedation, with episodes where they're completely normal. Now, we do have clinical criteria that we can follow, and this is from the Rome 4 criteria. But it's becoming really clear that there are atypical forms of this that do not follow this outlined pattern. But it seems to be very much neurogenic in its nature. And we think it might be related to an abdominal migraine variant. And so can be also associated with migraine headaches or a family history of migraines. There's also some strengthening links between this condition and the condition of dysautonomia. Now, dysautonomia is those patients that perhaps spend a little bit longer in the fight or flight response versus the rest and digest mode, if you will. And then unfortunately, like a lot of these other conditions, I don't have a blood test. I don't have an imaging study that can help me with this. This is purely clinical pattern recognition. Unfortunately, we don't have a great treatment for this. We do have some medications that work for some patients, but not for all. Cyproheptadine, or again, vitamin P, periactin, seems to help these patients, to some of these patients. Lately, we've been trying to use cardiac acting medications, not for their cardiac effects, but actually we think for the blood vessel effects and the nerve transmission effects. So propranolol is coming up as a very common medication for prevention. And then there's a newish technology called IB-Stim, which is a percutaneous electrical nerve field stimulator. There's a study that's about to come out that is going to show how well this works for CVS. This is a temporary management option, 4 to 6 weeks with this thing in your ear, on your ear, all superficial. And we're seeing some great data coming out of that. We'll see if that sticks with CVS as well. Regardless, you're going to want to really identify a good at-home abortive plan, and then an ER abortive plan as well. And your GI doctor can help you with this. Your neurologist can help you with this. That is different for everybody, but it usually involves hydration, analgesia or pain control, and sometimes even sedation with medications such as Ativan. Unfortunately, once you're deeply in that flare, once that flare has taken hold, there's usually not much else we can do other than supporting the patient through it, giving the system time to reset itself. Though there are some treatment options that are coming out that might help speed this up a little bit by causing actual full-on sedation and sometimes anesthesia. Uncommon reasons for chronic vomiting and things that your doctor should hopefully be keeping in mind. Eosinophilic esophagitis, or a condition of the esophagus, especially in younger kids, can just show up as vomiting or weight faltering. Celiac disease, again, going back to some of those food intolerance or food insensitivities type thing. This is an actual immune reaction to gluten, and it can be just vomiting, though it usually comes with diarrhea as well. Anatomical obstructions, partial or complete, will depend on how they show. If they're complete, they're going to be very sick. If they're partial, they could still have just sort of chronic vomiting here and there. So this should be looked into if all other things have been considered. And then very rarely, small bowel dysmotility, which can be difficult to identify and to test for, but certainly something that I think about. Risk and benefit oriented workup. This is something that hopefully your doctors are doing for you, but getting the right people in the room is step one, right? Dietitian, speech, swallow therapists, and a gastroenterologist. Usually that team is able to identify most of these. And something that I talk to my patients a lot, we may not be able to find the specific cause as to what is causing this, but we can certainly cross a lot of things off the list and at least be reassured that it's not one of those. It's not the same, I understand, but it can be just as helpful in at least telling you where to go next. And these are some of the studies that I do have the ability to do to sometimes distinguish these conditions from one another. Really quickly, let's talk about poop. So defecation concerns. This is, again, the Rome 4 criteria for constipation. You all have a vision of what constipation looks like. I I challenge you to challenge that thought. Constipation in children is very different than constipation in adults. It's not just about the number of poops per day or per week. It really comes with a lot of different signs and symptoms. And so it may be more than one thing at a time, but typically it's straining, withholding behaviors, low volume, lumpy and hard stools. If your child is verbal, has a way to communicate this, they might have a sensation of incomplete evacuation. My favorite question to ask, especially my younger patients, is, do your poops clog the toilet? Because that really is a category in the Rome 4. And then, we do still have a frequency amount that we want to see. And then, this idea of loose stools, which I'll talk about next, which is the idea of encopresis, right? So simply because your child is having a soft or liquidy daily stool does not necessarily mean they're not constipated. They could have something called encopresis, which is kind of the severe end of constipation, where they've essentially have a blockage, not complete, but still a blockage nonetheless, that is causing only the liquid stool to make it around and out. And so that might be what you're seeing on a daily basis. So something to think about. Why do we see constipation so frequently in the ASXL community? Well, again, this hypotonia thing keeps coming back, right? The low muscle tone both leads to impaired locomotion, but also the ability to bear down and really help the rectum push things out. That can be a big deal when it comes to defecation disorders. Hypothyroidism is a common cause of constipation. A lot of these medication effects, if you see the side effects, constipation's listed, pretty much all of them. So anything that slows down the gut can certainly lead to constipation. Um, this concept of decreased and altered GI sensation. If you want me to talk, I can talk your ear off about this. It is the concept of something called interoception, which is the ability to not just understand and be able to listen to the internal signals, but also know what to do with them. And this can be a really big issue in constipation and across the board. Dyssynergia, they could have everything else completely normal, but if they're not opening the door for the poop is not going to go anywhere, right? So if the patient is unable to relax the pelvic floor, to open the gate, nothing's going to move forward, and that is a very common issue in pediatric constipation as well. Withholding behaviors, also very common. This can be due to fear, anxiety, discomfort, lots of different things. Medication effects can cause withholding behavior. So a lot of different things that can cause this, and a very common also reason for a child to become constipated. And then the last three of them are pretty much common for adults as well. So I think you're familiar with them. I pressed the wrong button. Sorry. There it is. Um, how do I treat constipation? I use kind of a pyramid scheme here. The base, the bottom is probably the most important one, and the one that is going to lead to lifelong constipation management, right? It's about educating you, it's about you educating the child, it's about educating your village about what it takes sometimes to get a child to poop. Doing as much as you can to change the lifestyle and dietary choices for your child can make a difference, though not always. So don't go too crazy about adding that third portion of vegetables or adding that last 50 mLs of water. Sometimes it's probably not going to make that big of a difference, though you still should if you can. And then pelvic floor physical therapy for those that are able to participate can be really helpful, especially with withholding behaviors. To the second rung, I'm sure, is where most of you tend to live, which is the osmotic and stimulant laxatives, oral or rectal. These can be really helpful when used at appropriate doses and with appropriate follow-up. And then there are newer medications, prescription only, typically only available for adults, but can be used in kids that we have access to, all the way to cecostomy tubes, which is direct access to the colon, sacral nerve stimulators, especially for those patients that have neurogenic bowel, and then some surgeries that sometimes may be needed temporarily or sometimes permanently to deal with defecation disorders. Maintenance is just as important or maintenance regimen is just as important, making sure that, again, if able to, sitting or positioning the child in the appropriate sitting posture, schedule it toilet sitting again if it is relevant. But more importantly, is keeping a stool diary can give you a lot of information about their stooling patterns, what medications are doing what, and also whether we need more of a softener or more of a pusher. Treat constipation like you treat any other chronic condition. These medications are annoying. They come with side effects as well, but this should really not be looked at any different that you look at your own hypertension, your own high cholesterol. Constipation can sometimes just be there to stay. And so sometimes they just need that Senna for the rest of their lives. And we worry about the effects of that long term, of course. And I hope that your doctors are thinking about that as well. But if that's the medication that treats it, that's the medication that they need. And then this is my typical approach to management. I'm out of time, so I would go through it more in detail, and I can do that also with you guys. And these slides, I believe, are also going to be provided. But in general, when I meet a patient with constipation, the most important first step is really to try to disimpact them, right? If you have a plug, if you have old poop that's sitting there and hardening over time, it's nothing is going to help until we get clear that. And whatever that takes is really what the first step should be, and then introducing kind of a combination of the mushers and the pushers depending on what you've tried and failed and what has worked in the past. And in some situations, a rescue therapy can be crucial, right? So much like we have rescue plans for asthma patients, we should also have rescue plans for constipation patients, because constipation is a moving target, and sometimes even if you do everything right, you can get behind. And a quick way to do this at home can prevent hospitalizations and ER visits at 2 or 3 in the morning on a Saturday. So really quickly, closing remarks. Every patient is different. You are truly the expert in your own child. And who am I to ask you to do this? But sometimes you do have to advocate for your child. You do sometimes have to be like, no, doctor, I think there's something wrong here. I really feel it in my gut that this is what's happening. Some of us, most of us, really should respond to that language, and help you navigate what comes next. But I don't know your child as well as you do, so help me understand your child a little bit better. GI concerns are also very common in ASXL. They can be very disruptive to both the patient and the caretakers. So please bring those up commonly and as soon as you can, because usually these disorders are more manageable when they're identified initially. And then, you know, we're in this together. We're a team. A healthy provider, patient, caregiver relationship is one of mutual respect. If your doctor doesn't respect you, then it's time to look for a different doctor. And likewise, sometimes my patients disrespect me, and that's not a fun place to be. And so, really do your best to make sure that you keep those lines of communication open. You're as frank as you can be without, but while still being respectful. And I guarantee you that most of us should try to do the same. Thank you.
All right. Thank you, Dr. Velez. We have about 5 minutes for questions. So if you have a question, you have the QR code on the back of your badge to enter a question on Slido. We have one already, and that is the IB stim, the device behind the ear, is that an option for epilepsy patients?
Fantastic question. We don't know yet. It works through similar pathways. So you're probably thinking to analogous therapies such as vagus nerve stimulators that usually go into the chest. So yes, the IB stim is accessing peripheral or the little branches of the vagus nerve that are in the ear, but I don't believe that it is strong enough to change outcomes in seizures. But I'll be honest, I don't believe it's been tried either. So I think it's a really interesting next step in looking at what this therapy can do for seizures.
See some people typing away here. Yeah.
Depends on the disorder.
Could you repeat the question just for the audio? Thank you.
So I'm being asked whether there are good translational, meaning animal models, typically animal models, although cell lines could also be in there, which can mimic or can be used to target these conditions in the lab. There are good models, mouse models, I believe, for constipation that can be then and are often used to test medications on. I believe there is a diabetic gastroparesis model, mouse model that can also be looked at, though I'd caution the use of that for our patients because that's not the same mechanism of action that we are likely seeing in ASXL related disorders. But and then there should be also models on small bowel in colon dysmotility as well, though I don't know the specific ones. But we have the ability to grow colonoids, so especially for those constipation disorders, that should be, I know, easy to do, or at least easier to do.
All right. And so we've a couple of cyclic vomiting related questions. So I'm going to put these together for you here. So one is, does cyclic vomiting, can it recur after a few years? And then your thoughts on amitriptyline for cyclic vomiting.
Yeah. We'll go with the first question. So I think I really am just hearing from patients and from other scientists and doctors that treat this condition. I think that if what we see in ASXL is cyclic vomiting syndrome, is most likely a variant of what we typically see in our non-ASXL patients. I don't anticipate that this would be something that comes and goes, other than just sort of the typical pattern that we see. So if you're seeing multiple years of symptom-free periods, and that theoretically should not be the same thing as cyclic vomiting syndrome. But that said, as I said during the presentation, we are identifying atypical types of CVS, and I guarantee you that that's most likely what our ASXL associated disorders probably are suffering from. So I will cautionally say yes, that is probably a thing, where you will have years of no symptoms and then they'll come back. Amitriptyline, it's an old med. It interacts with just about everything on the surface of the earth, so it can be really difficult to neatly fit into patients' medication regimen, especially if they are on anti-epileptics, anti-reflux medications, anti-nausea medications. And so it can be really tough medication to fit in. It also takes forever to take effect, and it has side effects if you take it away too quickly. So it's a bear to prescribe, but for the people that it works really well. It's just about identifying those patients that it works for, right? So that we spare the unfortunate ones that it was not going to work for 3 or 4 weeks of a medication ramp up, only to find out that it didn't work, and then 3 or 4 weeks for a wean. So it's a good med. It's a good medication to have on your toolbox, but you have to be really careful how you use it because it does cause cardiac side effects.
Thank you. Okay, and I think this will be our last question. Do you have any information regarding inflammatory bowel disorders in the ASXL-related disorders, and specifically ulcerative colitis? And then the second half of that question is your thoughts on specific testing for follow-up and biological selection that might work for this group.
Okay, IBD. I believe in the natural history study, there were some that were identified to have IBD, if I recall reading. Is that right? Yes. So it's rare, even amongst the ASXL disorders, and but should be fairly, again, looking at it from, kind of my peds GI hat, fairly easy to identify, right? Those come with some stereotypic signs and symptoms. We have blood tests to test to at least screen for it, and then endoscopy usually confirms the diagnosis. And so, at least in the identification realm, it should be fairly straightforward to identify those disorders. I don't have a percentage or a risk as to what risk this population is at for developing these inflammatory disorders, but I'm sure in the future we will have that more information regarding that. And then meds, oh boy, I mean, it's right now in the age of infliximab and TNF alpha inhibitors, that seems to be the go-to, at least depending on the severity of the disease. And so these are every 4 to 6 to 8 week infusions of a primary biologic that can treat the condition, and it does a fairly good job at treating those conditions. But any more specifics than that, I fear about answering, because we have other meds that we have access to, especially for UC, that are just a little too specific.
Well, thank you. Thank you, Dr. Velez, for a great talk. We really appreciate it. So we're headed to a coffee break now for 30 minutes, and then we'll be back in the